joining us again. And if you've just joined us, we are talking to Dr. Hanekom in a few minutes. And thank you for joining us for World Fertility Day. We've got a full lineup up until 9 this evening. And our next speaker is Dr. Hanekom, and he is from Avitas Fertility Clinic. Thank you very much, Dr. Hanekom, for taking time out to join us this evening and to answer some of our questions.
Thank you, and thank you very much for inviting me. I'm pleased to be here.
Thanks, doctor. So I'm just going to get straight into the questions. What treatments are available when faced with infertility?
So obviously fertility is a very complex issue affecting a lot of women in their reproductive years. So the type of treatment available would obviously depend on the cause of the fertility and the pathology, and it can range from something as simple as lifestyle modification and weight loss in a lady that might be anovulatory, to something as complex as IVF or ICSI treatment, for either severe male factor or something else. And included in this whole spectrum are a whole range of things that we use to treat your fertility surgery also being one of them. So if we can just sort of start with the most simple, I would always look at my patient's lifestyle and see if there are any lifestyle issues that might be affecting their fertility. And here, obviously, weight being a big contributor to especially anovulation, especially in your patients with PCOS, but it also contributes to male factor infertility. So weight loss and lifestyle modification, including cessation of smoking, simple things like coffee intake, alcohol intake, any other illicit drug use, those type of things is almost the most simplest form that can often correct some infertility issues. The rest of the fertility treatments then sort of escalate and build on that and is more pathology specific. So as lifestyle modification and weight loss can be a simple way to induce ovulation and correct hormonal imbalances, you might need to assist in that sometimes in ovulation induction, or with ovulation induction, and that would be another form of fertility treatment that is available. So we've got various drugs available to induce ovulation in a woman, and obviously regulate her cycle and make sure that she's got a regular ovulation. Along with this then comes close monitoring at your fertility clinic or by a fertility specialist to obviously ensure adequate follicular growth, measuring hormone levels, estrogen levels, as well as pinpointing the day of ovulation, obviously, so that one can time the sexual intercourse more accurately. If there is, however, mild male factor infertility or abnormalities on the semen analysis, one can add an intrauterine insemination to the ovulation induction. Intrauterine insemination then obviously allows us to prepare the sperm, get a higher concentration of motile sperm and deliver it into the uterus, bypassing the cervical mucus closer to the fallopian tube, and also time it more closely to ovulation, with or without ovulation triggering. And then the next step on top of that would be then something like IVF treatment, where we take the process out of the body and stimulate the patient with what we call gonadotrophins, exogenous FSH or LH, to retrieve a form of hyperstimulation of the ovary to retrieve numerous eggs, which we then aspirate, which is a surgical procedure performed under anesthesia, and the fertilization then takes place in vitro, meaning in the laboratory, either naturally by what we call IVF, or then we assisted in certain cases with what we call ICSI or ICSI, intracytoplasmic sperm injection. So this is sort of the range of fertility treatment. And there's various that then fit into this whole spectrum depending on the specific pathology of the patient.
Okay, so I'm actually not going to ask the next question, which was what is IUI, IVF, and ICSI, because you've actually explained each one of them now, so which is perfect. What is the percentage of success with these treatments? And I think maybe that might be a difficult question, but you know, does your percentage increase even better with IVF compared to ICSI? What is that percentages?
Yeah, so your success obviously is determined by numerous factors and by your pathology and by other confounding factors that contribute to your fertility. So we know that the biggest predictor of any fertility treatment is female age. All right, so that is the first thing that women need to understand. And if there's one message that one should get out to women, and maybe not even women on this platform, maybe broader, because I think the women on this platform have already realized that they struggle with infertility. It's the women out there that are delaying childbearing, and that's going to be struggling with infertility in a couple of years, is to get the message out that, you know, female age is the most important factor and is the biggest predictor of success. So any of the treatments that we discuss is age related. So if you look at IUI, which is sort of our entry level or our most basic form of assisted reproductive treatment, you're looking at the most, depending on what sources you read, you know, a 15 to 16% success rate, with maybe 25 to 30% of women falling pregnant after 3 IUIs. It doesn't get much higher than that. So like I said, per cycle about 15%, with a plateau in success rate after about 3 to 4 cycles, where most of the women that would have fallen pregnant with IUI will fall pregnant. This rate does sort of decrease with age. So that is in your younger population that I quoted now. We see a slightly higher success rate with single parents or same-sex couples that don't actually have infertility, but that has just got a logistical issue. Their success rate might be a little higher, but none higher than 16 to 18%. As your age increases, this level will drop to below 10%, you know, when you reach the age, you know, of the 33, 35, and as low as, you know, below 4% above the age of 40. So this is for IUI. So not great success rates, but it is a very easy, non-invasive type of treatment that we offer, and very acceptable for a lot of our patients. And like I said, if utilized in the correct way for the correct patient with the correct counseling, can be quite successful. Then if we move over to IVF success rates, that is dramatically higher than IUI. And one can understand that just due to the technical nature of the procedure, because we take so much more control of every aspect of the fertilization. We control the stimulation, we increase the number of eggs that we get, we harvest the eggs, we control the fertilization, we control the incubation, as well as the selection of the embryo. So there's a lot of variables that we control for when we perform IVF, which we don't when we do IUI. So with IUI, you are still sort of you leave it over to the sperm itself to swim up, the fallopian tubes to pick up the egg, the fertilization to take place in the body. Whereas with IVF, you're removing all of these variables and you're controlling for that. So that allows us to get a much higher success rate with IVF. Once again, this is age dependent. So if you will look at the general sort of trends in IVF worldwide, they quote about a 35% success rate, but this includes good prognosis, younger people, as well as poorer prognosis, older people with lots of different pathologies. But it sort of as a rule of thumb, below the age of 35, you can expect below the age of 35 a rate around about 50, maybe slightly higher than 50. And this goes down to about 40% between the age of 35 to 37, and then down to less than 10% when a woman reaches the age of 40. So also here, a dramatic sort of decline in the success rate of IVF, between the age of 35 and 40. And I mean, that's almost like I've said already, that's the most important message, I think, to get to women, is that their success is dependent on their age. And the earlier they consult and get to the right place, and get the correct treatment, the better their chances of success.
Yeah. Okay. What is the recommended cutoff age for fertility treatments? Or maybe what would you say as in, like, there's definitely no way we can even attempt fertility treatments?
Look, there's always a chance, and I believe, in patient autonomy. I think the patient needs to decide. I will obviously give my medical opinion, and I'll provide her with statistics, and I'll make sure that she's well counseled and aware of all the options available to her and the success rate of the various options. But then, it remains the woman's choice. Whether she still wants treatment, and whether she wants to, wants to try. There's obviously a big part of woman needs to, they need to feel like that they've given it all before they give up, or before they move on to something like a donor egg or something, which is another form of fertility treatment that I'll also touch on now. But sort of just in general, to be more specific, sort of after the age of 42, I will strongly advise, my patients to consider the use of a donor egg, because we just know that the success rate of after the age of 42 with IVF is extremely low. It's not zero. We do see pregnancies, but it becomes a very difficult, painful process after 42, very expensive for the patients, not only financially, but also emotionally. So I will not refuse to treat a woman at age 42 or 43, but I will definitely make sure that she understands, what her prognosis is, and definitely have the discussion of donor eggs, with her. Donor eggs is one of the most successful treatments that we have in infertility or assisted reproductive techniques, and with our donor egg program, we achieve successes between 60 and 70%. So it's a highly effective form of treatment, if you compare that, to natural conception or to assisted reproductive techniques at that age. So definitely sort of, above 42, when you're talking about IVF, you really need to have a discussion or a serious thought about donor eggs. But some women need to reach that decision on their own terms, and be comfortable with it, and know that they've given it their all and tried. And that's different for every woman.
Yeah, and I know that Avitas has its own egg donor facility, as well as the sperm bank as well, hey?
Yes, yeah. So at Avitas, we've got a very successful egg donation program, where we obviously partner with egg donation agencies to offer fresh donation. In other words, stimulating a donor that the patient has chosen themselves, and we have screened medically, as well as psychologically, and then harvesting the eggs, and then obviously giving that to the recipient. Highly effective form of treatment. We also offer some other options like egg sharing, where we as the clinic will cover some of the costs, and then obviously we share the eggs, and then we utilize that eggs in our egg bank, which is then also available to our patients, where we've got an egg bank with frozen eggs that the woman can then buy, and then have fertilized and achieve pregnancy in that way. So it's basically three ways of doing donor egg treatment at Avitas.
That's awesome. How do you determine which treatment is necessary for a patient?
So obviously you need to see both parties, or both the whole couple. You need to see them as
Yeah.
a whole. So we know that about a third of fertility is female related, a third is male related, and the other third is usually a combination of the two. So after you've seen both of them, you will basically get from a thorough history and a good clinical examination, as well as an ultrasound and a basic semen analysis, you would sort of know more or less where the problem is. And depending then on the patient's age, you will make a decision. So obviously, if a patient is younger, we might be a bit more conservative, take sort of a slower route, trying to correct the physiology, like if lifestyle modification, ovulation induction, try and improve the sperm parameters. And our first prize in this group would be natural conception. If we can get them to conceive naturally, then that would be great for us. A big part of our conversations in these women and younger women is always, how to improve your natural fertility, and optimize your natural fertility. Obviously, if there's pathology that needs intervention, like tubal obstruction or endometriosis or male factor infertility, then that gets addressed, as well. We are also a Center for Excellence for Endometriosis Surgery, and we see that about 50% of women suffering from infertility do have endometriosis. And we see very good success rates with regards to spontaneous conception after endometriosis surgery. So that's also a big part of our treatment options in these women. And so that's sort of how you decide. Obviously, the older the women get, your time to pregnancy is a concept that becomes very important. To do a lot of conservative treatment, cycle correction, repeated cycles of IUI takes up a lot of time. And women that present to us very late don't have the luxury of going through all of these conservative steps, and we might sort of either skip some steps or move through these steps a little bit more quickly, to get to the process, of maybe initiating an IVF cycle. So my age cutoff there again is between 37 and 38. Where before that, I do think you've got some room, to be a little bit more conservative, and like I said, go through the steps, to try and conceive a bit more naturally. Whereas above 38, I would strongly counsel my patients, that one needs to, if you don't go straight to IVF, at least sort of have clear lines, and timelines and a reproductive plan to say, look, we're going to try for this for 3 months. If we're not successful, we do so many IUIs. If not, then by the end of the year, we go for IVF. So because we see that a lot of times with our patients, is that it's a tough journey. They get despondent, they get sidetracked, life happens, COVID happens, and all of a sudden you've wasted a year, and where you weren't really actively engaging and trying to fall pregnant. And a year at 30 is totally different to a year at 39 or 40, and that makes a dramatic difference. So yes, I will be a little bit more aggressive, with an older lady, and a little bit more conservative, going through the motions with a younger patient.
Okay. And then I was going to ask the question, what happens when it is the same-sex couple or a single intended parent? But you've just mentioned that you guys do have a great egg donor program, and Avitas has a sperm bank.
Yes, so that's a big part of it's a lovely population to work with, because they're so healthy and they fall pregnant easily, and very enthusiastic. So I actually quite enjoy that part of my job. But yes, so obviously for a same-sex couple that is a female that are females, we can offer sperm donation. We've got you can either have a known donor, which is someone that can donate to you, with the right legal things in place. That is a totally acceptable option. Or then we offer what we call anonymous sperm donation, which means that your identity plus the donor's identity is anonymous. You get a profile and you can choose the donor. So you get a lot of the information, the characteristics, physical, psychological, all of those things, and you choose a sperm donor. We will then either, depending on pathology or the age, we will recommend a form of treatment, either being at home insemination, intrauterine insemination, or then something assisted like IVF or ICSI. For male couples, it's a little bit more complicated because there you will have to get a surrogate, right? So that is also then a big step to take and involves a lot of legal parameters and high court order, etc. But we facilitate all of that. But then obviously a donor egg will once again be needed for that. For single parents, then also we offer those services.
Okay, awesome. I've got a last question. Ovarian drilling. Do you recommend ovarian drilling? But I'm also going to cut it into another question is, do you recommend ovarian drilling and when is it used? And then also, there's many doctors that don't recommend ovarian drilling. And why not? If you would a doctor that don't recommend it.
All right. So ovarian drilling and the place for ovarian drilling is very specific. So let me start that by explaining to the physiology of ovarian drilling, or what ovarian drilling aims to achieve. So ovarian drilling is a procedure performed laparoscopically. So it's a surgical procedure. It's an operation. You get a general anesthetic. You get a 3 or 4 port laparoscopy, and then you basically you drill, but it's electrical heat energy that you apply to the stroma and the cortex of the ovary. And the premise is then to basically destroy some of the cells that are producing a lot of androgens, i.e. male hormones. So this becomes relevant in women with PCOS. Because we think then that this can change the physiology in the ovary and then allow it to start ovulating again. So remember, PCOS, the main sort of cornerstone of the pathology in PCOS is an ovulation. So these women aren't ovulating, and that's where ovarian drilling has got a role in an ovulatory PCOS patient. But if you read the data, it's actually only to be considered in patients that are clomiphene resistant. In other words, patients that you are unable to induce ovulation with oral ovulating agents like clomiphene citrate or letrozole. So that is a very small subset of PCOS patients that you actually should consider ovarian drilling in. If you look at the data with regards to ovarian drilling was very popular, a decade or so ago, before the advent of gonadotrophins, which is FSH and LH, or Menopur or Gonal F, the FSH and LH that we are injecting. Since the advent of gonadotrophins, all the studies that have been done in women that are clomiphene resistant, comparing the use of gonadotrophins versus ovarian drilling, has showed that gonadotrophins has got equal, and a lot of studies, better live birth rates than ovarian drilling. I think that is where a lot of doctors have become hesitant in offering ovarian drilling, because we've got a much less invasive, safer option for treating our clomiphene resistant patients than ovarian drilling. The potential issues with ovarian drilling are the surgical and the anesthetic risk. It remains a risk. And then secondly, there is a shortage of long-term data about the effects of the drilling on the ovary. So the effect of the remaining ovarian reserve, because remember, you are destroying parts of the ovary and antral follicles. So there can potentially be an effect on the ovarian reserve. as well as adhesion formation afterwards. And the ovary is especially prone to adhesion formation, and this can negatively then affect spontaneous conception. So if you look at the newest Cochrane that was released, I think in February this year, it shows a decreased live birth rate in ovarian drilling compared to gonadotropin use. And then also, if you look at some studies analyzing a cost analysis, they also say that it is cheaper to use gonadotropins, than to go to ovarian drilling. So I'm not against ovarian drilling. I think it does have a place in a very small and select group of people, but I do think we've got very good alternatives in the form of gonadotropins and protocols for ovulation induction with gonadotropins that are very safe to use. And I think that is why a lot of doctors are steering away from ovarian drilling that might have been more popular, a few years ago.
Yeah, I love the way you answered that question, doctor, because there's been a lot of flack from one doctor to another of yes and no with ovarian drilling, and it's like women are saying, but why wasn't I given this option? So I'm glad to hear it's all because there's actually better options out there first. So thank you very much. Dr. Hanekom, please can you just give us details of how they can get in contact with Avitas Clinic, how they can contact you?
Okay, so Avitas Clinic is situated in Cape Town, in Pinelands at the Vincent Pallotti Hospital. You can email my receptionist at reception@avitas.co.za. We've also got a website, www.avitasfertilityclinic.co.za. Or our telephone number is 021 531 6999. And we consult obviously in person, but we also do Zoom consultations or online or telephonic consultations for people outside of town, even if it's just for a second opinion or something like that.
Awesome. Thank you very much, Dr. Hanekom, for joining us on this World Fertility Day and taking the time out to speak to women and educate women on what there is out there. And we hope to see you again soon. Thanks, Doctor. Have a lovely evening.
It was a big pleasure. Thanks for having me.
It's a pleasure. Thanks. Bye.